Welcome to the Medical Collective, your go-to podcast where medicine meets real life. I'm Dr. Keisha Davis, a pathologist, personal trainer, and your host. I will be joined by a vibrant team of doctors who are not just healthcare professionals, but artists, fitness enthusiasts, and advocates for change. Each episode, we dive deep into the world of medicine, from untold stories of the healthcare industry to the latest in medical advancements. We're here to bring your insights, answer your burning questions, and explore the art and science of healing. So let's get started and step into the world of the Medical Collective. Welcome in, everyone, to another episode of the Medical Collective with yours truly, Dr. Keisha Davis, personal trainer, pathologist, triple board certified, and host of this amazing show. This episode, I want to talk about some testing, and I think it's an important idea as we are all getting older. And I have a special birthday coming up in a couple of months. And we start to do the spring cleaning, and some of that includes making sure we're having all of the screening, like our mammograms for ladies, our prostate cancer screening, and also our colonoscopies if we need those. And when that time comes, one of the questions is always, what kind of tests should I get? Colon cancer screening is one of the few places in medicine where we can prevent cancer. Literally prevent it, not just find it. And here's what's changed. Cancer is rising in young adults. And I talk about this all the time. Specifically, colorectal cancer is rising. According to the American Cancer Society, colorectal cancer rates in people under 50 have been rising about 2.9% per year. That may not seem a lot, but it is making a red flag that we need to start looking at. And death rates under 50 have been climbing around 1% per year since 2004. So the question is, should I screen? It's which test is actually measuring what I think it's measuring. And as a pathologist, I'm going to tell you my personal preference and what I would do for myself and my family. Colon cancer screening tests don't check for cancer. They check for clues. They check for clues that cancer might be there, and those clues are very different. So let's start with the three categories of testing or screening tests. From a pathology standpoint, I put screening into three categories. Stool-based tests. Please don't cringe, because I know a lot of people are like, oh my gosh, stool-based tests. That's where we get men hung up, where they don't want to have anyone looking at their stool or having anything awkward done. But a stool-based test can provide a lot of answers sometimes. The second type of examination or test is a visual exam. That's my favorite. As a pathologist, I love to see things, and that's where a gastroenterologist will visually look to see if they find something. Then they biopsy it and send it to pathology. Last test is the blood-based test. These are up and coming. There are some blood-based tests that can be more of a tumor marker that are just used to look at reoccurrence of cancer. And then there are some up-and-coming ones that can help as well. And I think they're adjuncts. I equate colon cancer screening tests to having a healthcare team. There's not just one person that you need, but it's the combination of all. In addition to that, it depends on your risk factors. And I think that's where we all need to. If we're having a family reunion, let's have that conversation at the family reunion about what our family's cancer history risk is and what your personal risk factors are that may put you into a higher category so that the guidelines I'm giving you may not even fit. So let's start with the stool-based test, first of all. If a screening test is negative, that doesn't mean that there's no polyp, that you don't have a lesion. It kind of lets you know that you might need to have additional testing just in case, but it also can be reassuring at times with the screening test. The stool-based tests are used when you collect fecal material and you send it over to the lab. And the lab will look at it to see if you have particles of blood or DNA, depending on the type of test. It uses a chemical reaction And the chemical reaction for some of the stool-based tests, or the ones that are looking for blood, will be a reaction showing that there's a part of blood in there. And that's usually a heme, or part of the blood chain is hemoglobin. So looking for a part of the breakdown of blood is what tells you, ding, 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 there's blood. Now, if you're having colitis, if you have diverticulitis, if you have something else going on, you can have a positive test, and it doesn't necessarily mean cancer. Also, when you get a fecal test done and it's positive, it doesn't localize the source of bleeding. And I will talk about, in particularly, one of the fecal tests that's more generalized won't tell you if it's an upper bleed or lower bleed. And you know what sometimes causes bleeding upper bleeds? Is if you have esophagitis, if you have H. pylori gastritis, that can cause bleeding. And that test can be positive on some of the tests, on some of them. Also, there's limitations in some of the tests on if you're taking certain medications or you're not following the directions, and it tells you don't take vitamin C or NSAIDs and you do, you can get a false positive test. So across the studies, one of the tests which has the lowest sensitivity, meaning that if you have cancer, that you may get a false negative. A false negative. The sensitivity for this test is like around 68% to 88% if it actually has cancer. Now, we've kind of phased out those tests, and those are called the GWOT or GFOBT test, the GWOT test. Now, when I was in training in medical school, I remember these tests very well. If you get a rectal exam and then have a fecal occult blood, that does not replace your colon cancer screening. It does not. But it is the method by which stool was collected or looked to see if you had blood in your stool. With the fecal occult, actually what they do, and this is kind of can be uncomfortable, you all. It's probably the messiest of all of them, is traditionally when you're doing it at home, is you're collecting the stool and different parts, and then you have to smear it on this little card, and then it's sent off. Yeah, that's with the fecal occult test. That's the first one. That it is a chemistry test that we're looking for a reaction, an antibody reaction, and if it's positive, it says there's blood, but it could be upper, it could be lower. Also, one of the problems with the fecal occult test, if you're taking NSAIDs, like ibuprofens, if you have taken vitamin C tablets, if you've taken liver, some type of meat like my husband would eat, then you can have a false positive with this test. And it tells you, a few days before the test, do not consume these items. So you have to follow the directions. And sometimes I know it can be hard to follow the directions. So that is why that test has phased out. And then we get into a step above it. And there's now a second line of those tests. And those are the FIT tests. But we have to be careful because it's a fecal immunochemical test, but it's for a portion of the blood called the hemoglobin. It is not the same as the FIT testing I will talk about for DNA. So these FIT tests can be collected at home. You get a stool sample at home and you collect it for the lab. And, that's the ease of it. It uses antibodies to look at hemoglobin. It makes it more specific for lower GI bleeding. So you remember I said with the hemoccult, if it was positive, you could even have gastritis and have a positive. But with this, it's more specific that you are having a lower GI bleed. However, it doesn't say why, right? Again, it could not be cancerous. It doesn't necessarily mean that. In addition to that, I'm going to talk about the polyps in just a minute because you can have a polyp and you could have a negative test. You also can have a polyp that could be precancerous, not a benign polyp, and have a negative test if it's not so advanced that it's causing bleeding. Because it's looking for, the blood or occult blood, hidden blood, and they're thinking that this polyp or an invasive cancer is going to cause this bleeding, and then they're going to detect it. I hope that makes sense. Hello, listeners. We want to remind you that you can catch The Medical Collective on all your favorite podcast platforms. That includes Apple, Spotify, and YouTube. Be sure to hit that subscribe button so that you never miss an episode. We're also on Libsyn, and you can find us on all social media platforms as The Medical Collective. Do you have thoughts or questions? Please don't hesitate to reach out. We love hearing from you. Now let's get back to the conversation. So these are usually done annually, once a year. There's no food restrictions with the fecal immunochemical. There's no restrictions with food or drugs like it is for the occult testing. So the FIT testing, you can eat regularly and take the test and it won't affect it. And it does have a better sensitivity for, especially if you're looking for actual cancer, but it's still around 79%. Hence, we want to get close as possible. If it's my loved one, there's still a 20% chance that if you do have even a high-grade polyp, that it could not be caught with the FIT testing, right? It's easy, right? I think sometimes we think easy is best. And if easy prevents us from getting the best screening, then it's not best, because later on the line, you're going to have something more serious done. This is why someone can do a stool test and still later get diagnosed. They didn't do anything wrong. It's just that biologically, the tumor was early along to where it wasn't bleeding, or it just didn't pass through. It just didn't catch it. And that happens. Hence why the type of testing that can be done, and still stool-based, we're still in the stool-based test, is a FIT DNA test, where they're looking for parts of your genetic material, DNA or RNA, from the tumor. And it's looking for abnormal DNA markers. And this makes this, and I'm sure you guys have heard of some of this, is Cologuard. There's Cologuard and there's Cologuard Plus. Those look for DNA, genetic DNA that's mutated. And it has shown with Cologuard and Cologuard Plus, even Cologuard Plus better, that they can detect colorectal cancer up to 92% of the time. 92%. And Cologuard Plus can even do better than that. Yeah. So those are promising results. Now, if it's a tubular adenoma or a precancerous polyp, they're not as good with detection with those still. It's way better than it is with the other two tests I talk about, but they're still not 100%, because they're fecal tests. They're collecting your fecal material, and you still have to go to the next step. You still have to go. And you know what the next step is? A visual examination. And the way that we visually exam now, and I've had done, and I will tell you, I've had done before the recommended age. So because we've seen rising cancer rates, the age used to be 50 if you're average risk to get your colonoscopy at 50. Now it's 45. And with Cologuard as well, in 2019, they changed it to 45. You can get Cologuard. It can be recommended by the doctor, and you can get the Cologuard test. Now, it hasn't gone below 45, even though we're still seeing rising cancer rates in the 30 to 40-year-olds. It's not at a high enough rate to where they're recommending it. But what I'm thinking, and what some people are also presuming, is that we might need to rethink that. And the Cologuard, not being as invasive, could be a good possibility to use in the younger people, depending on your risk factor. The colonoscopy and the sigmoidoscopy, which is limited, one of the portions of your colon towards the end is called the sigmoid colon. Now, the full visualization is the full colonoscopy. That's what we recommend. You do have to prep, you all. The prep is minor inconvenience. It's not eating for a while, and it's cleaning out your colon. Because if you cheat on the prep, your gastroenterologist will either tell you you had a poor prep, you have to come back, or we couldn't see everything. We think we saw something in your colon, but we could not finish. And I've seen that before in colonoscopies where because of fecal material, they could only go up so far. There's been sometimes so much fecal material to where they can't visualize the entire colon. They could be missing a lesion in your colon. So make sure you get it right. Get it right so you can get out of there and not have to go back. But it is the gold standard. It's the creme de la creme. If it was my loved one, I would do a baseline colonoscopy. That means if you are low risk, I'm high risk. I have a lot of family members with cancer, so I'm in a different category. I'm getting the colonoscopy. I don't qualify for Cologuard, but it would be advantageous to you to get a baseline colonoscopy so they can look around your colon. If you have signs or symptoms, that changes things. If you have a history of colitis, like inflammatory bowel disease, whether that is Crohn's or ulcerative colitis, you will have to get screened more often. So you're not a Cologuard candidate. If you have a family history that's concerning, if you have Lynch syndrome, those things put you in a different risk. And so your gastroenterologist will talk to you about what's best for you. Okay? Now, the reason why we do the colonoscopy is because we're looking for changes in the mucosa, whether it's red or inflamed, that shows that you may have some type of inflammatory thing. And then flat lesions or outpouchings. A polyp simply, it's not a complete diagnosis. It just means an outpouching. It's just like a protrusion. Because sometimes what a doctor thinks is a polyp actually is just benign tissue that just happens to push out. Sometimes it could actually just be a lipoma. It could be a hyperplastic polyp, which are the good polyps. The hyperplastic polyps are the good polyps. But then there's this progression of polyps that are called tubular adenomas, and then there's serrated lesions. And the serrated lesions progress faster than the regular adenoma. Those are the ones that unfortunately can be missed with the fecal test because they grow faster and sometimes they don't have a positive fecal occult test because they don't believe they're on the other side of the colon, they're on the right side. So those can be missed. That's why I always recommend a primary or baseline colonoscopy. It's for that gray zone that the Cologuard just can't get. They just can't. There is another type of visualization. Okay, take that out if you can. There's another type of procedure that can be done to visualize your colon, and it's the CT colonography. Not widely done, not sure if all insurance companies cover it, but it's able to take pictures of your colon and see large lesions pretty well. Now, it still has a sensitivity of 90%. That means the lesions that are 10 millimeters or larger can be seen, but if they're smaller, they can miss them. And I've seen 1 millimeter, 2 millimeter cancers before. And if they find something on the CT, they still have to do a colonoscopy. So hence, again, why not just do the baseline colonoscopy? And if you end up getting a tubular adenoma in that colonoscopy, you will have to continue to be seen more often. So you will have to just be getting colonoscopies. Now, there's another category that I wanted to mention, and those are blood-based tests, like tumor markers, for instance. Have you ever heard of CEA? I know there's so many abbreviations. CEA is carcinoembryonic antigen, and it is not a screening test, but it's a tumor marker that can help us for monitoring known disease or reoccurrence. For instance, you have colon cancer, you get a resection of part of your colon. CEA is a blood test they can use to monitor to see if it's come back. If they see a spike in your CEA, years down the line, they might be concerned and may want to make sure that you don't have reoccurring disease. So that can help. Some blood-based screening that's also done is SHIELD. Now, SHIELD is a blood-based screening that, again, does not have the highest sensitivity, so around 83%, but it only detects about 13% of advanced precancerous polyps. And if I talked about before, a precancerous polyp, it would be a tubular adenoma with high-grade dysplasia. So it's very atypical, but it hasn't broken the fence. When a tumor breaks the fence, that's when it's considered, or the basement membrane, it's considered invasive cancer. So they still can't catch everything with that. I think we're still rising with these blood-based screening tests. And again, until we can perfect them, I still think a baseline visualization with a colonoscopy and biopsies if needed should be done. And for everyone, to be honest. For my peace of mind, even if I was low risk or average risk, I would get a baseline colonoscopy. I would tell them, I need a baseline. The prep, the good sleep, I'll take it all to be assured that everything is clean in my colon. And that I know it. I don't have any polyps. I have a family history of colon cancer, but I don't have anything right now. And I can go to sleep at night knowing I will be here for my family. If your goal is cancer prevention, make sure that you also are doing all of the dietary things. As they say, most cancers can be prevented with preventable measures that you can do: diet, exercise, not smoking, all of these things, 50% of them. So do take that into account. You still need to have a strategy together, and it is going to require you telling the doctor your risk factors, your family history, and any limitations you have to having those procedures as well. So blood tests can increase your screening uptake. Fecal test can help as well and be non-invasive. But at the end of the day, you have to make sure you have, just like a cancer team or a healthcare team, you have to have the right sequence of events and procedures done. And talk to your doctor about it. Your primary care physician, as well as your gastroenterologist if you're having signs or symptoms. Because we all want to prevent cancer, and it's one of the most preventable cancers. It really is. The best screening test is the one you will complete. Hence why I say, if we are dealing with inequities, if we're dealing with someone that we know is not going to get into the doctor's office, we have a loved one, a husband, a male companion that just will not have anyone do a colonoscopy. You might have to put some fear into them, but you also can say, okay, let's start with the Cologuard. Let's start with the Cologuard. Can we at least do that? And let's see what that is. Now, if they are high risk, if they have a family history, you're really going to have to talk to them. At the end of the day, it is their choice, but the best screening test is one that you complete and complete correctly. If this topic hits home, please share this episode with someone that you care about. Also, listen to one of my favorite episodes, We Should Not Be Cancer Shaming, as well as the rising cancer in younger populations that I have shared quite a few times because it seems that that is one of the most hot topics going on right now in this world. Thank you guys so much for being here. And again, I want to tell you, negative does not mean that you don't have cancer. It's a screening test. A screening test is going to guide your physician for the next steps. Complete them, trust the process. And at the end of the day, we want you to be here, to be there for your loved ones and for yourself. Until next time, thank you all. Thank you for tuning in to the Medical Collective. We hope today's episode has left you with valuable insights and a new perspective on healthcare. Don't forget, follow us on social media for more updates and behind-the-scenes content. I'm Dr. Keisha Davis, and it's been a pleasure to share this time with you. Stay healthy, stay informed, and we'll see you in the next episode, where medicine continues to meet real life. Please note that the content provided in the Medical Collective podcast, including text, graphics, images, and other material, is for informational purposes only. The content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. The views and opinions expressed on this podcast are solely those of the individual authors and guests and do not represent those of the Medical Collective, its staff, and any affiliated entities. The appearance of content on the podcast does not imply an endorsement. Neither the host, Dr. Keisha Davis, the co-host, or any guest of the podcast bear responsibility for the accuracy of the content provided or the use of information received through the podcast. Reliance on any information provided by the Medical Collective podcast, its employees, writers, or guests is solely at your own risk.